Okay, welcome everybody. So good to see you. We are well into 2021. So glad to be back with you with our host, esteemed epidemiologist Glenn Grossman. And I'm Rebecca Berman, thrilled to be our moderator this evening. Thank you to everybody who sent in terrific questions during the week. We have so much to cover tonight. Glenn will, of course, take us around the country and around the world. And to give you a preview of some of the topics we will discuss tonight, we'll talk about the different COVID variants. We'll talk about whether you should take acetaminophen or any other type of medications after getting the vaccine. I pre-registered last night here in New Jersey for the vaccine. If you live in New Jersey and you haven't yet pre-registered, you might want to check out covidvaccine.nj.gov. So that's covidvaccine.nj.gov. And certainly if you live elsewhere, you might want to Google what's happening in your state to see if you can pre-register and get a text or email alert as to when you might be eligible to receive the vaccine. But lots to cover tonight. So if questions arise during our conversation, please send me a text or a chat privately in the chat box, and I will try my hardest to weave your question into our conversation. And if we do not get to your question this evening, Glenn will absolutely get to your question during our conversation next week. So here goes. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology, forecasting, and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs within the United States and abroad. All views expressed today are his own. Okay, so as usual, Glenn, please give us an update on how things are looking with the COVID-19 pandemic here in the US and abroad.
Thanks, Rebecca. Welcome back, everyone. Let me open up my Zoom on my laptop. All right, so this is the familiar covidtracking.com. As we've talked about in previous weeks, the key metric here to be looking at is this solid line, the average over the last week, the daily average over the last week. You see that we've had this blip from the New Year's holiday and Christmas, and so that's recovered now. So now we have, I think, a more accurate representation of what things are looking like. And the key thing over here is three key things that I'm looking at. One is hospitalization rates are still rising. Two, the number of daily deaths on a weekly average is now above what we had for 9/11. So the number of people that died one day in 9/11, we're now hitting that every single day going forward. We're actually exceeding it every single day. And so the models that we looked at previously, the forecast models, were assuming that we'd be reaching the peak of deaths by around the middle of January, so in another week or two. But the problem is, and this is the third point. Whoa, my screen just turned color. All right. So now the problem is that the forecasts were assuming that we would reach our peak of new infections by the middle to end of December. And as you can see, we are still increasing in the number of new infections. And so this is worrisome because we haven't hit the peak yet. And so that means let me go quickly. So here is where this IHME model, in terms of their most recent projections, so this is December, January, February. they were assuming we'd hit the peak under almost all the scenarios they were looking at. The red case is or the peach or whatever this is the worst case scenario, and we're still on the worst case scenario timeline, unfortunately. And one of the main reasons is we haven't rolled out the vaccines fast enough. So the highest risk are not getting them fast enough. And so this is hopefully with the change of the administration, we'll be able to turn this curve around. But unfortunately, right now where we are, we're not there yet. Let's see. So yeah, so that's where we are in the U.S. You can see on a state by state level so when you see red, that means that the number of new infections is increasing, and green means the number of new infections are decreasing. And so in terms of the R level, and so this is you can see we're really in bad shape right now where we are. A couple other things that I can point out here before we go on to questions. There's so many interesting questions this week, so I want to not spend too much time on this. But what we should start seeing in the next couple of weeks when we hit our peaks of new cases is that, so right now this graph is showing us the number of new, let me see if I can zoom in a little bit, the number of, the week in which each state hit the most number of cases that they've had so far with the COVID-19 epidemic. And you see that this last week, a lot of states were at the most. So the virus is still raging strong. In the next couple of weeks, we hopefully will start to reach the peak. And so we'll see more and more states that shift. And as the weeks go on, hopefully this number will get less and less in terms of the most recent week. But this will be where we'll start seeing the first evidence that we've started to hit the peak. And then let me go to the global. All right. So globally, I wanted to pull out a couple things that were interesting globally. So there's a few countries here that you'll notice. First is the United States. So this is the same similar data to what we just looked at, that we're in the third surge, and the third surge is not going well. But the other things that I wanted to point out were that, so for instance, UK. So we've talked about the United Kingdom variant. It's a little bit hard to see. I apologize. Let me make it a little bit bigger. So the UK variant, you can see that one of the reasons that that people are talking about it and it's so disconcerting is they were going through their first surge or their most recent surge for the fall, the same as other countries. Then they started to get it under control, but given the same controls that they had, suddenly this new variant was able to break out. And so this new UK variant is 50% to 70% more contagious. And that's why we see this sharp spike. It's even more pronounced in Ireland. And you can see based on the previous surges versus this current surge, it is insane. And so that's why there's so much discussion about the new UK variant. I thought it would be interesting to look at, pardon me, always talking makes me cough a little. I thought it would be interesting to look at some other countries in Europe and around that also started to have these really sharp spikes, because that might be evidence even before there's genetic testing of the sequences to see what's going on. Interestingly, Israel, so although not in Europe, we see this very recent spike there. And I don't know that there's two major causes for what could be causing it. One could simply be that it's spreading based on insufficient control due to not enough mask wearing and physical distancing, and that lockdowns were insufficient. Or it could be evidence of a new variant that's spreading a lot there, and I'm not sure what the story is there. United States, we don't really have any evidence that it doesn't look like Ireland. Ireland is sort of the stereotypical expectation if we had a new strain that sort of broke out and went crazy. Portugal, interestingly, there's this spike there, and so that could be representative that there's either the UK strain or rather the UK variant or a similar or some different variant is starting to spread there. Lebanon, curiously, this might be related to its proximity to Israel, although I don't think that there's a lot of travel between the two countries. So this could be also something else going on there with a variant that's spreading more. The South Africa variant, was not the same as the UK variant. They have some similarities, but they're not the same variant. And so you can see that in South Africa, one thing that's interesting about South Africa is that because it's in the southern hemisphere, it's currently summer there. And so summertime, this is a respiratory illness. We've seen the seasonal variation that we've talked about previously. This should be really when they have no surge there. They had that first surge when it was wintertime for South Africa, fall and winter, but now it's their summer. So really, this should be the least time that it's traveling, and yet we're still seeing this surge. So clearly, the variant that we see there is more contagious and is also something we're tracking. United Arab Emirates, there's a little bit of a spike that we can see in the most recent couple of weeks, and so that's also something that's interesting. I don't know why though. Again, whether it's just simply the management of the disease that's insufficient, or whether it's the virus itself that has a new variant. And finally, the third main variant that people are tracking is from Nigeria. Right now, you don't see any big spike like we saw in the UK and Ireland and South Africa, but Nigeria is also one that's being followed for a couple reasons. Other than that, let me go to what else do I want to see? We can look at the map just at a high level, and then we can go to vaccines. So if you were to look at the world, which we're looking at right now, to see where most of these cases are occurring right now, you see that there's some countries in Europe that are being hit somewhat hard, and then also the United States isn't doing very well. But surprisingly, even in the southern hemisphere, like Argentina, this is summertime for them, and yet they're still being hit pretty hard. So other places, Panama, I was seeing earlier, also is not doing very well. Anyway, let me go on to the vaccines, and then we can go into questions. So first of all, so this is where vaccination is mostly occurring right now, most rapidly. China and US are really have been doing the most vaccinations. However, as a percentage of the population, which I think is a better way of looking at this, so per million people, it's not quite the same. I think that this isn't the best way to look at it. This, I think, is the best way. But that's not a percent. Is that what I want? All right, I think this. All right, so this, I like this. So this is percent. So what we're looking at here is the percentage of the population that's already been vaccinated. So interestingly, Israel right now has over 20% of the population. They're the global leader right now in terms of how quick they've been able to get the vaccine out. Next is United Arab Emirates, then Bahrain. United States, we had a head start, and we had a slow rollout, so we're still only at 2%. We are slowly increasing, but we're not going nearly fast enough. Then you'll see some parts of Europe, Denmark, UK, roughly at the 2% mark. Italy, Slovenia, a lot of other countries are still struggling to get up to speed with vaccinating the population. And so yeah, we have a long ways to go. And with that, the one other thing that I can say is sort of, that doesn't help me very much. Let's just keep it there. So we're so early in the vaccination process. Some countries are doing extraordinarily well, and a lot of the rest of the countries still need to catch up. Still have a lot of work ahead of us. All right, Rebecca, let's open it.
So we've got a great question from Harry. Harry, I'm going to unmute you, or ask you to unmute. Let's see. Can you unmute? There you go. We've got a great question, Harry. I'll introduce your question about distribution of the vaccine. So here we are at 2%. Israel is at 20%. So we've got a bottleneck. So Harry, if you could please ask your great question about distribution.
So the distribution question goes back to what the Trump administration has done. They had planned on holding back 1/2 of the vaccine that was available in order to qualify the first people that got their vaccination to have the second dose available for them. The Biden administration upcoming has planned on reducing immediately, making available all of the vaccine that is available, 100%, getting it out immediately, and then hoping that the production is going to be able to keep up with the second vaccination that's required. So you're going to immediately get a larger percentage of the population that has had the first dose, but you're going to run into the potential problem that you won't have the second dose available for a percentage of those people. So what will that do in the overall process of keeping our population vaccinated and controlling the virus?
That is a really good question. Let me reshare my screen. All right, so there's two parts to that question. The first part is, I think, in terms of actually getting the drug or the vaccine administered to patients. Because the problem is right now, there are not enough people actually administering the virus that we have on hand. And so the problem is right now, it's all hands on deck. There are so many new cases, so many hospitalizations. Hospitals across the country are being hit really hard. And the problem is the very nurses that we need to administer the vaccine and other healthcare providers to administer the vaccine are the ones that are working and spending all their time working extra hours to keep people alive in the hospitals. And so it's a real problem. Yes, Harry, did you have a follow-on question? You're currently on mute. Rebecca, can you? Okay.
Harry, I will ask you to unmute. Okay.
The follow-up question from that is, I've got it from reliable sources in New Jersey. The problem is financial, that it's not just the people that are available. The New Jersey government does not have the money to pay the people to administer the drug.
Yeah.
Vaccine.
This is a problem. This is something that has to come from the federal government. So, because the federal government can write money, they can just print money, they can take out loans, the federal government can just spend money without having it at source. Whereas state governments have to balance their budget. And so that means that either during the COVID-19 epidemic, when the economy is being hit so hard, the states either have to raise taxes when we're least able to raise taxes, or they need to cut services during the epidemic. And the states can't really do either. This is only something that the federal government can really address. And I think that the federal government has not sufficiently done it so far with the outgoing administration. So I think everyone is confident that the incoming administration with the Biden administration and the new Congress will make sufficient funds available. We'll be able to really drive it and get us what we need. There might be a ramp up. So it's not going to be on day one that we're going to be able to hit the ground running. But I think that very, very quickly, we're going to be able to get a lot more of the resources that are needed to really execute on this. But yeah. All right, so there's a couple other issues here with the vaccine, get one dose versus get two doses. There's a debate among policymakers about whether to even forget about the second dose. Just give, because if we could just give out a lot more first doses, then you could potentially vaccinate twice as many people. And so the question was, is it better to vaccinate twice as many people with only half the dose, or less people, but give them the full 2 doses that we had in the vaccine trials? So there's a bunch of issues here. The first thing is, in the vaccine trials, they were designed for the 2-dose regimen. And so we don't have a really big evidence base on just administering 1 dose. But we do have some evidence. And so what I'm presenting here is this is the key takeaway. This is from a study in the New England Journal of Medicine. And so this was looking at the arrows are the different doses. So dose was given in the first day versus 29 days later. And so this is the mRNA vaccine. And so basically what you're looking at is that there's 2 components to the vaccine that we talk about. One component is what you would typically think of it with a vaccine, where it prevents severe disease. But then the other component that we've also talked about is this idea of a neutralizing antibody, where it actually not just triggers an immune response to get the virus out of the body, but it also actually interferes with the binding of the virus to the ACE2 receptor. So those are two different things. One thing is to reduce symptoms based on getting the immune system to attack the virus. The second is where the antibody itself interferes with the binding directly, even without any immune system ramp up. And so what you see here is the second component, this neutralizing antibody component, that's not really contingent on this question of stimulating T cells and doing other kinds of things. It's this one component of neutralizing. The reason that this is important is because it's still an open question of how contagious someone might be if they could get infected after getting the vaccine. We know that when they get the vaccine or get the second dose of the vaccine, after and give it a window of maybe 2 weeks or so after the second vaccine, the second dose, people are roughly 95% protected from having severe symptoms, severe COVID-19. And that's great news. But the question has been, well, can they still get infected, but then just not have symptoms and still infect other people around them? And so what we found here is this is specifically looking at neutralizing antibodies, because that's what determines whether someone can infect other people, if they're how infectious they are. And what you find is that on the first dose, there's not a lot of antibody produced. There's some, and this is enough to reduce risk of symptoms by maybe 50%. But in terms of neutralizing antibody, enough to really interfere with the direct action of the binding to the receptors of the ACE2 receptor, you really need this booster shot that really creates this huge response. So you can see this massive distinction between the first and the second dose. And so therefore, this is really, really strong evidence that you need 2 doses. And so in fact, when you look at the FDA has made clear that all available data continues to support the use of 2 doses for each authorized vaccine. Now, some of the vaccines that haven't yet received emergency use authorization are being evaluated in the clinical trials for only a single dose. But the mRNA vaccines that have been released so far, definitely we need to have the 2 doses. The one other thing to talk about here is this question over here. All right, now this is it. So when we talk about vaccine coverage right now, the vaccine coverage covers all the variants that we know about. So there might be some variants in circulation that haven't been identified yet, just because we haven't been doing sufficient genetic screening, and we just don't know yet. But the ones that we have identified, the UK variant, the South African variant, and the Nigerian variant, we believe that the vaccines currently protect. The problem is, in order to have this really good protection, this neutralizing protection, we need to have 2 doses. And so one thing to look at is that, so the way to look at this graph, by the way, is, so this is December, when we have the early outbreak in China, and then how the genetic mutations have evolved over time. And you can see that it's gotten much more diverse. And the key thing I want to point out here is that it's not random. So what we see, I mean, it is random, but my point is that once you have some sort of drift in terms of the genes, then the new variation is all based on where the starting point is from that drift. So all the new mutations over here are all based on the seed that happened over here. And so that means that the diversity of the mutations is actually contingent on where the starting point is at each point in time. So it's not that the mutations are all going to be very similar to the initial strain. Instead, what you're looking at are branches that keep on branching out. And the reason that this is important for the vaccine story is that if there are some branches that are not very well controlled by the vaccine, let's say they're only partially controlled. If you only have one dose of vaccine, then that makes selective pressure for the branches that are not covered, that are sort of free from the vaccine. It makes them more likely to be the ones to spread. And so that the worry is that we might see a breakout, because say there's these few over here that are outside of the vaccine's ability to cover them, then if we don't have a really strong response, this is the story I'm telling here is the same story that we have with antibiotic resistance. That if you don't really hit it as hard as you can, as fast as you can, if you give a very low dose of antibiotics and stop it before the antibiotic treatment should be stopped, then you can sort of have a breakout of mutations that become antibiotic resistant. And the same thing can apply with vaccines, that with the viruses and the vaccines that we currently have, if you don't hit it strong and hard and fast, if it's too weak and you only have the one dose instead of the two, then what you could see is a breakout with vaccine, where you have similar to the antibiotics resistance, you could have a resistance developed for the vaccines. And so this is another really, really important reason why we need to ensure that everyone gets the double dose. All right, I think that answered all the questions there. Oh, the one other thing with the variants that I was going to talk about is in terms of genetic testing. So some countries are doing amazingly well at testing the genetic sequences. So as you can see on this graph, there's a lot of mutations going around all over the world over time. And so it's important. We don't even know. It's right now, it's invisible to us in a lot of countries what's going on. These are all that we know about, but there's a lot more that we don't know about because we're not sampling enough of the genetic material that's out there. And in fact, when you look, the United States is actually 43rd in the world in terms of how well we're doing on taking genetic samples and sequencing the genetics of the outbreak in the United States. And part of it is just because we're so overwhelmed with cases. Going back to what I just mentioned earlier, though, if we had seen, where was it? If we had seen, this is what I want to show. If we had seen, so similar to the United Kingdom where we saw this breakout here, if there was some variant that was really crazy in the United States, we'd start seeing evidence of it at some point. And so we really haven't seen strong evidence of a breakout like they're seeing in UK or Ireland yet. So right now it's not a worry, but it could be something that breaks out. So and we do. One other thing I don't think I just showed earlier is this map. And so now this is this lineage, the B1, the B.1.1.7 is the UK variant. We've talked about the UK variant, the South African variant, and the Nigerian variant. The UK is the one that's the most common now. And so we've started tracking it around the country in the United States. The ones in dark blue are places where we found patients who have the UK variant. Because we're not doing enough testing, I am very confident that there are some of these variants, that there's some of the UK variant that's in circulation in other states. And also within these states, where this is just the tip of the iceberg in what we're seeing. Florida, they found 22 cases out of the 63 total in the country they've found so far. And California is the other state, 32 they found of the 66. And these others, so Colorado with 3, Texas with 1, these other states, Pennsylvania, New York, Connecticut, with 1 or 2, you know that if one exists, that it was just from sampling that they found it, that there's going to be all of these chains of infections that are going on under that's this iceberg that we're not seeing it. And so that means that because we know that that variant is 50 to 70% more contagious than the regular one, then that means this is something that is very likely to explode in the next few weeks if we don't get it under control. It's another reason why we really need to be accelerating how quickly we vaccinate, how everyone can't stop wearing masks. We really, really have to, for the next few weeks at least, we have to redouble our efforts to make sure that we physical distance and wear the masks and stay outdoors as much as we can and do all the stuff we've been doing, because this is a much more contagious disease that we would need to worry about. Right now, our country doesn't look like Ireland, but if we're not vigilant, this could be something we need to worry about as this variant starts to spread. All right, Rebecca, back to you on some more questions.
You can count on us, Glenn. You have our full support. We will absolutely comply with your requests. Absolutely. So, of course, the story would be really boring, right? Like, as if it's not crazy enough, this whole COVID thing. Now we have all of these variants. I mean, I cannot believe that, of course, now we're talking about this. So, Sandy, I'm going to ask you to unmute. Oh, you are unmuted. Please ask your question.
Glenn, my concern is if these breakouts of mutations can occur if people don't get the second dose. It's kind of a free fall as to whether people go back for their second dose. I mean, they may forget. They're older people, a lot of them. They may, not that older people ever forget, but that's another issue. But they could move, there are a million reasons. They could just be irresponsible. So that's my one question. What will happen if that happens? How far or how long will it take us to get, that's kind of rhetorical, to herd immunity, if that is an issue? And my other question escapes me. Like older people forget. So there you go. Thanks.
So those are important points. I think that right now the logistics are really poor in the country. And I'm hoping that when the new federal government management team comes in, they're really going to have the resources they need, and the logistics will improve. So we'll be able to make sure that everyone is tracked and followed up. If people only get their first dose, then the worries I mentioned are going to be legitimate worries, because not only will the symptoms not be protected at 95%, the protection won't be as strong. We have the two worries. One is we worry that the persistence of the effect won't be as long, and then the second is that the neutralizing antibodies won't be as effective, and so then the spread could still occur. And it's not just a question of symptoms, but also the spread. So it's a really good point. We really need to ensure that everyone gets their second dose. One thing that might be easier is that with the new vaccine trials that are still being evaluated, some of those are only a single dose. So at least with those, you won't have to worry about getting the second dose. The worry about some of those is that we don't know how effective they're going to be. And these RNA vaccines are way more effective than anyone was anticipating. And so we don't know with the new single dose vaccines, I think that are based on the adenovirus and these other things, we don't know how effective they're going to be yet. But early evidence is suggesting that they might not be nearly as effective as the mRNA vaccines. All right, Rebecca, next question.
Okay, so we're at 2%, but sorry, the dog wants to be part of the conversation tonight. So let's hope that ramps up very, very quickly, and many more of us on this call and beyond get to take the vaccine very quickly. And so a question has come in: is it okay to take acetaminophen or ibuprofen or some other type of medication after the vaccine?
That is a great question. And here is the answer. So there is this open question about, a lot of times people, it's not very, very common, but it's sufficiently common about sometimes people get symptoms when they get the vaccine shots. With the first dose, there will be some symptoms. And then with the second dose, there are likely to be more symptoms because your body will already have this immune reactions that you're trying to boost. And so that initial immune response might be there, and so might give symptoms. And so, for instance, if you get a headache or a fever or muscle pain, can we take the Advil or Tylenol? And the literature is unclear about this. There have been a bunch of studies. What we do know for sure, it sounds like so far, based on my reading of the literature, is that people who take, at least in children, but it seems like in adults as well, people who take Advil or Tylenol at the same time that they're vaccinated, like at the same minute, in anticipation of a symptom, it seems like it does interfere with how effective the vaccine might be. So that means we recommend not taking Advil or Tylenol with the vaccine. The question that's a little bit uncertain is, well, how long do you have to wait until you can take the vaccine? And so there's this hypothesis that the very symptoms that you might be getting, the headachy feeling and the if you have a slight fever, are the exact things you want your body to feel, because you want your body to think that it's been infected with something and needs to fight it. So if you are able, say you're not working, or you can take the day off, it's probably better just to take a nap and not to take the Advil or Tylenol or any of these NSAIDs or pain medications. But if you do, it's probably not the worst thing in the world either. The longer that you can delay taking it after you get the vaccine, the better. So like I said, don't take it as soon as you get the vaccine. Don't just immediately pop the Advil or Tylenol. It's better to wait. But at the same time, it doesn't seem, if you take it multiple hours afterwards, it's not the worst thing in the world as far as I can tell. The literature is not 100% clear on this, but I think right now the guidance is that most people are not taking Advil or Tylenol if they can help it.
Okay, good to know. All right, so we have a question from Debbie. Debbie, if I can ask you to unmute. There you are, about somebody who had a reaction.
So, hi guys. I just read an article about a doctor in Florida, 56 years old, completely healthy, took the vaccine, and he threw a clot, had a stroke, and passed away. I know we said that before, that we should all take the vaccine, but now they're saying this could be a side effect. Have you heard of other stories similar to this? Is this a fluke? Is this something to be highly concerned about? What are your thoughts, Glenn?
Yeah, so I haven't seen this directly. One thing that we do know is that people with no existing symptoms throw clots all the time. So a lot of people have a first heart attack, a first stroke, and a thromboembolism, and they've never had one before. So when you're vaccinating so many hundreds of thousands, millions of people, you're going to expect diseases that naturally occur to occur in people who are vaccinated anyway, because the vaccine is not going to protect from a random person just getting a heart attack that they would have had otherwise. In the vaccine trials, we did not find a higher elevation of heart attack, stroke, and blood clots in patients who received the vaccine and did not get COVID-19. So it could also be some people get the vaccine and get COVID-19 just coincidentally at almost the same time. And that could be another reason that they might have gotten a blood clot. But I mean, and all the high risk factors that people might have, you have to remember that a lot of people who are currently getting the vaccine, it sounds like the person you're referencing in particular was a doctor, but a lot of the people who are getting the vaccine right now are among the highest risk people. And what that means is these are already the people who are most likely to have heart attacks, strokes, or have blood clots. And so that means that they're going to be getting blood clots just because they're already high risk. And so we're going to be preventing it, but it's not going to be eliminating it from the population. It's just going to be preventing COVID-19 mediated clots, if that makes sense. All right, Rebecca, back to you.
Oh, okay. Thank you, Debbie. Thank you for that question. And Glenn, thank you for clarifying. Much appreciated. Okay, so thank you, Glenn, for telling us so much about the vaccine and where we are.
Oh, Rebecca, you're on mute.
I muted myself.
There you go.
How do you like that? Okay. It's not a Zoom call unless somebody mutes themselves and keeps talking, right? So there, we did it. Okay. So thank you for telling us more about the vaccine and where we are. And hopefully by this time next week, that percentage will grow significantly from 2% to, I don't even want to say, but hopefully a much greater number. Okay, so let's go back to talking about COVID-19 and the levels of contagion. And people, where people are still asking, a question came in about how long after people get COVID-19 are they still contagious? And when do we still believe that folks need to stay quarantined for 2 weeks? And how long are we finding that folks are protected? How long do the antibodies last? Do we have any updated information on those questions?
Yeah, we have some great information about this now. So this comes from the CDC has been looking at all the studies. So you know that this was the novel coronavirus back in February, March, April, when we really didn't know very much about it. But at this point now we know a lot about it. And so these are questions that we actually have some good answers to. All right, so the first thing is people with mild to moderate disease typically are no longer contagious within 10 days after the symptoms start. So 10 days for mild or moderate. It's occasionally really, really rare if someone only has mild to moderate disease that they might be contagious up to 15 days later. But usually the vast, vast majority are no longer contagious within 10 days for mild to moderate. Now, there's two exceptions. One, with severe disease. Among people who have severe disease, it can last as long as 10 to 20 days. So within 20 days, they can still be contagious if they have severe disease. Okay, that's the one, and that's the first exception. The second exception is among people who are immunocompromised or are immunosuppressant because they're on immunosuppressant drugs or they're immunocompromised in some way. For instance, cancer patients who might be on immunosuppressant drugs and other types of people with other kinds of diseases who are immunocompromised. We have found that those patients, not all of them, but occasionally, you'll find that they can be contagious for far, far longer. In fact, a few weeks ago, we talked about one case that was published where someone was immunocompromised. She had an immunosuppressed system, and she was contagious. She was asymptomatic, but contagious for at least 3 months before they gave her enough antibodies and were able to knock it out. So she might have been contagious for even longer if they hadn't realized that she was infected and had been giving her antibody treatment to try to knock it down. So that's an important exception. For the vast majority of people, like I said, mild to moderate symptoms within 10 days. I think the CDC is still recommending, I think, 2 weeks to quarantine after they've been infected, just across the board, but 10 days is what the evidence is saying. A couple other points I want to make. So occasionally people will recover from the initial illness and then subsequently develop new symptoms within weeks. What they found are people who sort of have the first illness, the acute illness, and then it seems to go away and then they develop new symptoms, that none of these people are contagious. So they've looked a lot at these people, but none of them are contagious. So that's really good news. People can get new symptoms again, but that seems more like it's based on the immune system responding in exaggerated ways, and it's not because they're contagious. So that's good news. Another point I wanted to make is that even though people are not contagious, a lot of people are going to continue shedding virus for weeks after they have been infected. In fact, they were looking at studies, and they were showing that even after 3 weeks, there was a lot of viral shedding. In fact, up to 12 weeks. That's a long period of time. 12 weeks, people were still shedding virus. But like I said, 100% of those people were no longer contagious after 20 days among the severe and after 10 days among the mild or moderate, with the other exception of the immunocompromised. And so that means that even though people are shedding virus, they're not contagious. And so what that also means is that if someone gets a PCR test, a diagnostic test, just because it comes back positive does not mean they're contagious. What's most important is if it's 10 days after they first get symptoms, 20 days after they're severe and got the symptoms, etc. The one last thing is another source of evidence. I think the 3 things I said earlier are the most important sources because they were really looking at culturing the cell to see if it was replicating in the cells. But one thing that they looked at in a real world evidence type of thing is they did a large contact tracing study, and they demonstrated that high-risk households and hospital contacts did not develop infection if their exposure to a case patient started 6 days or more after the case patient's illness onset. So even though we're saying 10 days for mild or moderate and 20 days for severe, In the real life example, 6 days was sufficient because after that point, even though they might have technically been contagious, they were probably not shedding enough virus that was contagious that it really made a huge amount of difference in the real world. So I wouldn't push your luck. I wouldn't say, oh, this one study said 6 days. I would use the 10 days for mild or moderate and 20 days for severe as the good reference, with the exception again of this immunocompromised. And in that case, and there's a worry, if there's a worry that you're living with someone who has who's immunocompromised and they might still continue being contagious longer, then it might be a good idea to schedule an appointment with an infectious disease specialist. But otherwise, these are the key things to be looking at. Back to you, Rebecca.
Okay, good. Good to know, Glenn. Thank you. Much appreciated. And another public service announcement. Way back in the beginning, you told us to get one of these. Oh, I'm so bad with this camera. Pulse oximeter. I even learned how to say it properly. So if you haven't already gotten your pulse oximeter, I highly recommend it. And mine doesn't read very quickly. Otherwise, I would take my oxygen live. But I'm not going to do that. But if you haven't already, I highly recommend that you do. It's like $25, and you should know what your oxygen level is on, sort of try it once a week and just know, so that some people, their oxygen level falls. Is that right, Glenn? And you kind of almost don't even realize if your oxygen level is falling.
I would do it for people who are higher risk. I would probably do it daily, because some people, their first clue that they might be infected, even before they have symptoms, are that their oxygen level is lower. And they might not even realize that they're breathing a little bit more than they normally do. They might not even realize it, but the oxygen level might be lower. And so if you use the oxygen, the pulse oximeter every day, and if it falls below, say, 95% or so, then it would be a good reason to call your doctor and tell them that this is the case. If it's persistently low, then your doctor might at least want to be aware of that. Otherwise, it's a good thing to find out, because that might be a good reason to go and get a test, even if you hadn't been thinking about it. And so yeah, it's important. I would do it much more frequently than once a week. If you're high risk, better to be doing it daily.
Okay, so if you're high risk, brush your teeth and check your oxygen. How about that? Is that
Great.
good? All right, we're going to go with that. Brush your teeth and check your oxygen. So while we're talking about teeth, actually, someone in our audience asked a great question. Is COVID-19 a dental disease? What are the main dental symptoms?
Yes, so this is actually an interesting question. There are a lot of ACE2 receptors in the mouth. And so let's go into this a little bit. We know among long haulers, so long haulers are the people who have chronic COVID. Our best estimate is around 10% of people who develop COVID-19 symptoms will go on to have this chronic form of the disease. And so there's still a lot unknown about that, because we don't know how long it's going to last into the future, because we haven't even had SARS-CoV-2 as an epidemic for a year yet. So we don't know how many years it's going to last. But what we do know is that there's a symptom that occurs more frequently than we'd like, where people who have chronic COVID, they've described oral problems such as teeth falling out, sensitive gums, teeth turning gray, and teeth cracking. And so I thought that it might be interesting to dig into this a little bit after the question arose. So let me come here. All right, so these are the top 5 manifestations. So apparently it's somewhat common for people to have gingivitis, increased gingivitis, after exposure. And this is typically thought to be due to the immune response rather than to the virus itself, in terms of being contagious. So another way of saying this is someone could have a persistent gingivitis in the mouth, but that doesn't mean that they're contagious after the 10 days or 20 days that we mentioned previously, we just talked about. So the 10 to 20 days is the more important thing, except unless they're immunocompromised, the 10 to 20 day mark is what's most critical. But they might have persistent gingivitis because of this immune response. But I just mentioned that people could have another set of symptoms. Their symptoms could improve, the symptoms could come back weeks later, but they're no longer contagious at that point because it's all immune mediated. So this is something that could occur in the mouth, but it's not something to worry about in terms of being contagious. Something else that's common is dry mouth. One reason is that a lot of people are wearing masks, as they should be. And so because of the increased mask wearing, people might be breathing breathing differently in the mask. And so people might have drier mouth, and that could be one reason. We also know that that the salivary glands can get infected, and so that could also impact why the mouth might be dry. The third most common is ulcerations, and actually a breakdown of the tissue. And this could be due to direct, like this vascular problem could be due to direct viral replication within the cells that's causing it. But the tissue, this anomaly could persist longer than when the patient is still contagious. So again, the 10 to 20 days is still a good reference point here, even if the symptom is found. Fourth, cracked teeth. So as a lot of people on this Zoom call have probably also experienced, it's a very stressful time for a lot of people to be experiencing the epidemic. And when people have stress, then they're more likely to do teeth grinding and clenching. And so that produces more cracked teeth. And so dentists tend to be seeing more cracked teeth during this time. And then finally, something we've talked about a lot before is loss of taste and smell. Roughly 50% of people who have COVID-19 either lose their taste or their sense of taste or their sense of smell, or both. And it's possibly up to 80% of people who are losing these things. So this is also another common complaint that dentists will see. And so those are the main, there are other sequelae that occur in that dentists see, but these are the main ones that they're seem to be reporting. All right, Rebecca, back to you.
Okay, thank you, Glenn. Sandy, if I could ask you to unmute, please. Sandy has a question about viral shedding, please.
Glenn, you had mentioned viral shedding not being contagious, and I'm sorry, all this time I always thought if you walk into an area where somebody was shedding virus, that you were then going to catch it, possibly. So if it's not the same, then if people are working in your house or whatever, you might have work being done, and they're shedding virus, and I come into the house afterwards, does that mean that I could catch it, or it's not the same?
So the way that I think about it is, think of fireworks. When you explode a firework, you see this brilliant display at first, then the ashes all fall to the ground. If someone were to have a test for fireworks, they might see before the firework goes off, oh yes, this is a firework. Or after the firework goes off, after it's just ashes, they might look at the ground and see the piece, the remnant that's left over, and say, oh yes, this is a firework too. The difference is that the firework that's already exploded, that's on the ground and it's just the ashes, is harmless. There's nothing that you have to worry about. It's just the ashes. It's just the remnant that's left over. And so that is sort of similar to the shedding that goes on for weeks afterwards, is that it can no longer spread. You can no longer infect anyone with it. So does that make sense? It's sort of like it's this idea that it's dead. It's the way that we know is they take these pieces, these fragments, and then they purposely try to infect cells and infect animals, and it's called culturing. It try to culture the remnants of the virus. And the reason we know it's not contagious is because despite their very best efforts, they can't get any cells infected or any other animals infected. So that means it's the same thing that we're talking about. If it's within 10 days of mild to moderate symptoms, then we need to assume they're contagious. If it's within 20 days of severe symptoms, assume they're contagious. If they're immunocompromised, it could be far longer. If they're asymptomatic, we have no way of knowing because they don't know that they have symptoms either.
Period, yeah.
So to be safe, we need to assume that everyone around us is contagious and doesn't know it. And that's what it means. However, now that a lot of us are getting COVID-19, among those people who have had the symptoms, have the positive test, there's a lot of concern of how long they're contagious, and now we have the answer. But if you haven't been infected, assume everyone around you is contagious.
Okay. Thank you.
It's a good way to go about daily life, right? Since we just don't know, and since so many people are asymptomatic, we've just got to assume everybody has it. Okay, so we are almost at the top of the hour. I guess, why don't we wrap up with one more question? Another great question that's come in is, can COVID-19 cause psychotic symptoms? And do these psychotic symptoms go away?
So that is a really good question. And unfortunately, we don't have a really good answer yet. Right now, this is just a New York Times article. I looked into some of the literature, and typically, whenever I present just a regular news article for the lay press, I always will have looked at the scientific literature supporting it. And if I feel like the lay news presents it better, then I'll just cut and paste the lay news. And in this case, I looked at the literature. So it's very, very rare, but there are we do know that SARS-CoV-2 can infect the nervous system. And we have seen evidence that SARS-CoV-2 can get into the brain. So we have seen a very, very, very rarely some psychotic symptoms. Right now, we don't know how common it is, except that it's really, really rare, and we don't know how long they'll persist. The one thing that it's hard to think about when we study this kind of question is that it's the same thing that I just mentioned earlier, is that some people might be coincidentally developing psychosis and also get infected at the same time. And so it's hard to know that if it's a psychosis they would have had otherwise, or whether it's developed specifically from the ACE2, or from the SARS-CoV-2 rather. But so it's very, very rare. It's nothing that I would be concerned about at the population level that we haven't been thinking about. Rebecca, I just saw you type something, but I didn't read it.
Okay, I said, is it okay? I said that was our last question about psychotic symptoms, but my question to you, Glenn, was, can we actually ask just one more question? And we discussed, I think it was last week or 2 weeks ago, about the safety of schools. And you showed us some international research. And if you could just remind us about, or maybe you have some additional research of what things are looking like in schools, that would be really terrific. Since some of us on this call and those watching after on YouTube have some interest about how things are looking in schools for both students and teachers.
Yeah, so I'm going to come to this. When we last left it, I'm sorry, I made these graphs kind of super huge. So I'll just jump in here. Basically, what we are talking about is, let me see if I can see this. This is students. All right, so this is students aged 6 to 13 years old. And so we're looking here on the bottom axis, the x-axis. This is the number of cases in the towns in which they live. So regardless about the schools or about the students or anything, this is in the towns in which they live. And this is the reported cases among the students. So this black line in the center, if the students had the identical risk, if they went to school or stayed home. So if they stayed home, presumably they'd have the same risk of just the regular risk of being in the town. And if they went to school, then the question is, do they have more risk by going to school, or less risk, or the same? If they had the same risk, you'd expect that they would be on this black line. If they had an increased risk, you'd actually expect them to be in the red, in the pink. So the higher the risk of going to school, the more they'd be up in the red. And so counterintuitively, this was surprising to a lot of us, but we've been finding it consistently in all of these studies the vast majority of studies that we're looking around the world, is that it turns out counterintuitively that kids, so this is at the age 6 to 13 before high school, kids who go to school are less likely to get infected than if they had just stayed home. And I think that the primary reason for this is that when kids stay home, the parents think that they're at very low risk because they're staying home. And so the parents are still going out maybe to visit the friends occasionally, maybe to have the play group because they figure they're in this secure bubble, so they don't have to worry as much because they're not going to school. They have the play group and then get infected with the play group when they didn't realize. They take more liberties in terms of maybe going out and doing slightly more activities in the public. Maybe it could be the case that the students who are going to school, the parents are so worried about what they perceive to be this increased risk of going to school that when they're home, they don't let them have any kind of enhanced exposure. So maybe those parents are the ones who, when the kids are going to school, that say, no play group for you, no additional exposure because we want to reduce your risk. So we don't know exactly what's driving it. All we know is that numerous studies now have demonstrated that the students that are going to school age 6 to 13 are far less likely to get infected with SARS-CoV-2. Now, that's the first thing. Let's go on to this question then. So that was age 6 to 13. This that we're looking at is the staff. And what you see here is the staff are in the red. When the staff have in-person classes, they are far more likely to get infected with SARS-CoV-2 than they would have been if they had just worked remotely or with what the average is for the towns in which they live. So that means that if schools reopen, there needs to be approaches where perhaps the students can be at the school, but maybe it's a teacher's aide that's in the class with them, but the teachers are remote or something. There's some sort of process where we can protect the teachers. That once the teachers get vaccinated quickly, then this would be great, because then once the teachers aren't worried, we don't have to worry about the teachers, then immediately the student's risk is going to be great. It's going to be very, very low. And so then that would be a really great time to open up the schools. But like I said, this is the big thing that's challenging. The one other thing that we talked about previously, and let me pull this up. I think so this is the junior high and the high school. And you'll notice here that although it varies a little bit, the central tendency is right on the black line. So typically the ones who are students age 14 to 18, so the post-pubescent students, these are the ones going through puberty. These are, and after, these are the ones that have roughly the same risk when they're in class. So these these students are attending class in person. They have roughly the same risk as the general population in the towns in which they live. So so there's other studies. I like the way this is presented the best, and that's why I have it here. But this has been demonstrated in numerous studies at this point. Did you have other specific questions about that?
I think that this is really helpful in demonstrating, I think, kind of the general questions about whether the kids should be in person or at home remotely. And
Yeah.
This is really, really helpful. Okay, so I think that does it for today. We do have many more questions, but we have lots of time. Looking forward to being together again next week, same time. Please keep sending your questions in during the week. It's really helpful. This way it gives Glenn time to prepare. Thank you, Glenn, for all of the preparation that you've been doing for all of these months. And we really, really, really appreciate all of the in-depth research that you bring to these screens every week. Sandy, I agree. We can't thank you enough. And we look forward to being together, same time, same place with you and your wonderful fireside chats. Everybody be safe, be well, and have a very, very good week. Take care.
Thank you very much, Rebecca. Thank you very much, everyone. See you next week.